Hey.
Hi, Dr. Kishan.
Hi, Daryl.
Hi, thanks for being with us today. Thanks for being part of Mailcare's faculty for our conference today. Could you tell our audience what you do and where you do it, please?
Sure, and thanks very much for the invitation. It's a true honor to be here. So I'm a radiation oncologist at UCLA. I run the prostate radiation program, and some of my specific areas of interest and expertise are in SBRT for prostate cancer and novel technologies for that, as well as the treatment of high-risk prostate cancer.
Great, and just so everybody's on a level playing field, just what does the SBRT stand for?
Sure. It stands for stereotactic body radiotherapy. Another name or acronym is SABR, stereotactic ablative radiotherapy. And what it is a type of advanced radiation for prostate cancer that really condenses the treatment into as few as 5 treatments. Some of your listeners may be familiar with a particular brand name device called CyberKnife. That's kind of a type of device, but the general treatment is called SBRT.
Okay, and you're here. We're both here today with Allen Edel, who's part of Mailcare's wonderful group of volunteers, and he'll be doing the presentation with you. So I'll turn it over now to Allen.
Thank you. One of the many innovative things you're working on is a brand new kind of linac for treating prostate cancer, the ViewRay Meridian linac. Could you tell us about that and how it's different from the old style linacs?
Sure. Yeah, so traditionally, all of our radiation treatments have been X-ray based or maybe CT based. What that means is when a patient comes for their treatment, we're using an X-ray to aim our radiation. And typically, we put these markers into the prostate called fiducial markers. They're tiny gold seeds, maybe the size of a grain of rice or so. And they show up on any X-ray or CT machine, and we use those to kind of indirectly track the prostate. And I think as every patient understands very well, you can't see the prostate so well on a CT scan or obviously not on an X-ray either. That's why when we're doing a workup for prostate cancer, we get a prostate MRI. An MRI has much better resolution and really shows us the cancer in a much better detail. The problem is, historically, we have not been able to solve a basic physics problem. It's hard to have an MRI-guided radiation device because of the interaction between a magnetic field and the radiation. It's a complicated physics issue that has recently been solved. And the Meridian device, which is the type of MRI based treatment that we're using here at UCLA, essentially has a low field MRI that's running continuously while a patient is being treated. That means we can track the prostate using an MRI. So the way the prostate is targeted and delivered is actually, and the radiation is delivered, I should say, is using an MRI, which has much better resolution and ability to visualize the prostate than a CT scan or X-ray. So we don't need the fiducial markers at all. We would just be looking at the prostate. But I think beyond just the fact that we see the prostate, the real power in this machine and in general with MRI-guided radiotherapy is something called real-time imaging. And many of your listeners may be familiar with the CyberKnife system, as I mentioned. So CyberKnife is a type of device. It's a brand name, but one thing it does have is a repeated X-ray imaging during the treatment. So every 90 seconds or so, an X-ray is taken and it shows where the 3 gold markers in the prostate are, and that allows it to kind of triangulate the position of the prostate. The MRI-guided machine, this one in particular, the Meridian, has a real-time imaging, which means it's actually taking an MRI during the treatment as well. And it's taking a frame 4 times per second. It's taking an MRI. If the prostate moves out of what we call a preset boundary, a gating margin, then the machine will actually turn off. So the radiation won't be delivered. If it moves out of position for more than 120 seconds, there's a hard stop. We have to pause the treatment and do some kind of a realignment. But even if it moves out for just a few seconds, it will turn off until it moves back in. The only hard stop will be if it's out for more than 120 seconds or 2 minutes. And so that type of real-time monitoring, I think, is essential. And it's essential because the prostate moves. So that's something that we might not appreciate as much, but the prostate is between the bladder and the rectum. As the bladder fills up and the rectum fills up and empties with gas, the prostate is going to be moving. And it's only moving, maybe we've measured this, it's only moving maybe 4 millimeters in each direction. But we need to be very precise. This is high value real estate. 4 millimeters is actually a big deal. And so these types of abilities to account for motion, I think, are critical.
Especially with SBRT, where you only have 5 treatments,
right,
and each one has to be amazingly precise.
That's correct. Yeah, exactly right.
And how is from the patient's point of view, how is it different? Is the prep different? Is the time spent in the machine different?
Yeah, great question. So the prep is only different in the sense that we don't need the markers placed, right? So I'm of the belief that for other types of SBRT, for X-ray or CT-guided SBRT, you really should have the markers placed. I've had discussions about this, maybe in international settings. I have many colleagues in India that I trust a lot, and if it's hard to get fiducials placed, it's a different consideration. In the US, you should be able to get fiducials placed, and that should be a standard of care for CT-based radiation. In this case, because we can see the prostate directly with the onboard MRI, we do not need to put markers. Other than that, I actually do think a patient prep is important. I know there's some divided camps on that, but I think having a full bladder and an empty rectum is pretty important. What it means is that it will standardize the anatomy. And so I recommend that for both patients getting CT-based radiation as well as for MRI-based radiation. So that for my perspective, the prep is not different. The experience for the patient is a little bit different in the machine. So with a standard X-ray-based machine or CT-based machine, you're actually lying on a table and the machine is rotating around you. So it's not very claustrophobic. You're not inside a tube or anything like that. And with modern, what we call VMAT planning, the treatment can be as quick as 10 minutes. CyberKnife treatments can be a little bit longer because they're doing the repeated X-rays and moving around, so they can be on the order of 30 or more minutes. But a VMAT, or kind of volumetric modulated arc therapy plan, is really quick. The MRI-based treatment is slower. It's about 45 minutes inside of an MRI. So you're in there for longer. It's an MRI, and so many patients that have prostate cancer, they've had to have an MRI. It's a tight spot. It's not, the most comfortable thing. And some people might be claustrophobic. Obviously, there can be music. You can wear earplugs, and if needed, we can give a medication to relax somebody. But it is a tighter space, and the treatment is longer. And the treatment is longer predominantly actually because the prostate is going to be moving, and we're accounting for that. So the way I try to explain it to patients, and I think most of them have been accepting of this, and I've had very few complaints about the time of the treatment, is that that's time well spent, right? We're turning off the machine if the prostate is moving out of the goal target area, right? That's why it takes so long. The actual beam on time is not that different. The radiation is being delivered for only about 15 minutes of that time. The rest is really because of the targeting. But it is longer.
And during that time, the patient has a full bladder. That's a great question. So and a great point. So we have been a little bit more with the MRI machine. We're a little bit more lax on the requirement to have a very full bladder. We want it to be comfortably full, but you're right. They have to be able to hold it for about 45 minutes, right? So it can't be bursting at the seams full. Whereas perhaps for a CT-based treatment that's really fast, you could come in with a very full bladder. But I would argue, why are we doing the very full bladder? We're doing the very full bladder because we want to minimize the dose of radiation to the bladder wall. Think about the bladder like a balloon. We don't really care about the dose of radiation inside the balloon. That's water or urine, right? That's not going to be effective. It's really the wall. So we want it to be full so that less of the wall is going to be radiated. what's going to cause the wall to be radiated? Because we have to put a safety margin around the prostate because it's moving, right? And the margin that you need to use for an X-ray based treatment is bigger. For example, our historical X-ray based margin has been 4 millimeters, and with the ViewRay or the Meridian Linac, we're using a 2 millimeter margin. So it's a less amount of bladder that's going to be radiated anyway. So we are more accepting of a less super full bladder for these treatments.
And the smaller margin translates to less toxicity. Is that right?
So we are studying. I'll answer that the technical way. Yeah. So first of all, theoretically, of course, right, because less volume is being treated with radiation, and you can imagine a ball, right, and you have a margin around it of 2 millimeters versus a ball with a margin around it of 4 millimeters, which is twice that radius. Obviously, a much smaller amount of tissue is being radiated just by virtue of what we call an aggressive margin reduction, right? Now, does that lead to less toxicity? One would think, of course it does, but from a scientific perspective, you do have to try to prove that, right? Because this is a new machine, it's a little bit more expensive. So from a hospital side, getting this new machine is, and it's a longer treatment and all that kind of stuff. So we actually tried to prove this. We ran a randomized trial where patients that were coming to UCLA for prostate SBRT, we kind of basically flipped a coin. And either they got X-ray based or CT based radiation or MRI based radiation. And I don't want to get into necessarily the details too much, but let's say that we designed that trial to actually detect that the MRI would improve the toxicity, would have less side effects. And when you're designing a trial, when you think about how many patients you have to put on the trial, you think about how big of a difference are you going to see. And so we guessed we would see a certain amount of difference that would require 300 patients. And then we ran the trial. And we had a rule that after the first 100, we would look back and see, well, how many differences are we seeing? Is 300 the right number? Do we have to go bigger, or could we possibly go smaller? And of course, it's a still ongoing trial, so I can't, and it hasn't been fully analyzed. But what I can say is when we did look at the 100 patients, we saw something that led us to conclude that we could cut our sample size in half. Wow. And typically you can only do that if the difference that you're seeing is bigger than the difference that you predicted. You would never do that if the trial wasn't looking like it was positive. So I guess I can share that we obviously had a pretty positive early analysis after the first 100 patients were treated. But we actually are wrapping up, and the last few patients have been randomized. So our endpoint there was to look at the short-term toxicity, and we all know, short-term toxicity is one thing, long-term toxicity is another. But because long-term toxicity is thankfully, rare and it takes a long time to potentially manifest, we looked more pragmatically at short-term toxicity. We'll have our results by mid next year, for sure. So that's the longer, more technical answer to does it reduce toxicity. I can also say that now that we've closed that trial, my practice has basically been to offer the MRI guided radiation to essentially all patients. There are a few for whom that might not be the best choice. Those would be patients that are claustrophobic, or they might have an MRI incompatible implant, like a pacemaker or something like that.
And are you offering it to patients for primary radiation, recurrent patients, and whole pelvic treatment?
Yeah, so we are. So in the sense of somebody, sense of somebody that wants primary treatment or their definitive treatment, it's the first treatment they're getting for their prostate cancer. That's really who we studied in that randomized trial, and that included some patients that were getting whole pelvis radiation. And so that because we offer that as part of our protocol, and in the selected patient that we think would benefit from it, we offer whole pelvis radiation. So those patients were enrolled on that trial, and now we are offering it outside the trial. One other benefit that this device might have is that it has the ability to do something called adaptive radiotherapy. So what that means is we get an MRI before we treat, just like we would get a CT before we treat in the older approach of treatment. And if things look off, for example, if there's a loop of bowel that's falling into the radiation target, we can actually change it on the fly if we need to with the MRI guided machine. That does extend the treatment time, but that's a possibility. So because it has that possibility, we have been using it for patients getting the whole pelvis radiation as well. We have not needed to adapt very frequently, and not at all, in fact. And so thankfully, we haven't needed to extend the treatment times for that reason, but we have that as a tool for us to use. In terms of the recurrent prostate cancer, I'm assuming you mean for somebody that has a radio-recurrent cancer, or maybe they had
post-prostatectomy.
Okay, so they're kind of two different things. So for the radio-recurrent prostate cancer, which means somebody that has a recurrence after primary radiation for their prostate cancers. They got radiation maybe 5 years ago, their PSA is rising, they get one of these newer scans or an MRI, they find the cancer has come back in the prostate. We are using this device in that situation as well. It's not the only option for those patients, and that's a longer and separate discussion, but you can do SBRT, you can do brachytherapy on those patients. If I am doing SBRT, I would be doing it with this machine because of some of the benefits that I think it presents. For the post-op setting, we are using it. We're primarily using it for patients that are getting the shorter course of radiation in the postoperative setting, which we offer on our clinical trial. And that's for a pragmatic reason. First, we are able to do that same type of tracking. In this case, we're tracking the rectal wall, which is the back part of the target volume for someone that has a recurrence after surgery. So we're tracking that. There's no prostate, obviously, to track. But as you brought up, these treatments are longer, and I think that can be a little bit more of a challenge for someone that is a post-op treatment, right? Because they might have more difficulty holding their urine. So we haven't been using it in patients getting multiple fractions of radiation, meaning for getting the long course of radiation. We're more using it in patients that are getting a short course of radiation, because then, yes, the treatments are longer, but there's maybe only 5 of them or potentially 20 of them, depending on the type of treatment schedule that we're using.
What is really exciting to me about it is the ability to see soft tissue with the traditional kind of way of doing it. You couldn't, so whole pelvic treatment where bowels come into play, you can't place fiducials in there. So the ability to gate on the bowels to target everything but the bowels is very exciting, and the potential to reduce toxicity is really great, I think, with this new device.
Yeah, we've been having very promising results. We've been studying it. Actually, we're doing a trial of SBRT in the post-op setting, which is obviously that's a newer approach to the treatment. And we've been having very favorable early toxicity results with that approach. I think a lot of that is due to the ability of this machine to really track things, right? And as you can imagine, in the post-op setting where there's no target that's obvious and easy to aim at, our ability to track the rectal wall is a big advantage to this machine.
Let's move on to another one of your many clinical trials, which is treating high-risk patients with SBRT. We're all very excited about it. That's traditionally, only low and intermediate risk patients have been treated with SBRT. How is that coming along?
Yeah, so we opened a trial, a phase 2 trial of SBRT for high-risk prostate cancer in 2014. I was originally by Dr. Chris King, who was here at UCLA at the time. And we have had very favorable results. Actually, earlier this year, we published our results in coordination with 6 other centers from across the world. It was one of the largest series of patients that got SBRT for high-risk prostate cancer, with what we call a median or average follow-up of nearly 4 years, which is pretty good outcomes, a pretty good length of follow-up on outcomes. And the results were very promising, despite the fact that the use of hormone therapy, which is a separate piece of this puzzle, but is typically recommended for high-risk prostate cancer. The use of hormone therapy was kind of all over the place because there are different trials that were doing this, and yet the outcomes were still very good with this approach. And so we actually are now offering it as a standard of care option. So it was, patients in our randomized trial of the MRI device, many of them had high-risk prostate cancer. We will be opening future trials where we're looking at increasing the dose to certain areas of the prostate and maybe dropping the dose to other areas of the prostate. That will be open for patients with high-risk prostate cancer. And I think our practice of offering SBRT for high-risk prostate cancer, even as a standard, is consistent with the national guidelines. So in the United States, there is a organization called the National Comprehensive Cancer Network, or NCCN, and they put out a guideline document every year that in one place they talk about the different radiation regimens for prostate cancer. And ever since 2021, and potentially even in 2020, they have listed SBRT as an option for patients with high-risk prostate cancer, as a standard of care option. And this is based off of evidence from randomized trials. There was a trial out of Sweden that included patients with high-risk prostate cancer that showed same outcomes at 5 years, whether they got the long course of radiation or SBRT. Now we also have our data, which is with modern SBRT from an international perspective. So I'm very comfortable offering it off of a clinical trial. And I don't think that's a unique approach because it's now in the NCCN guidelines.
Are you finding that insurance companies and Medicare are covering it?
Yeah, so not all insurance companies, but many of them are. Yeah, that's a great point. So Medicare, I've not had any issues with, and many of the commercial insurances now, we don't either, because we can, at worst, if we need to do what's called a peer-to-peer, where they might initially say, oh, why are you doing this approach? We bring up the NCCN guidelines, we have our own publication, and we've been able to successfully appeal most cases. It's very rare nowadays to have someone refuse treatment with SBRT for prostate cancer when it's a primary treatment. When we get into the other circumstances of using it for post-operative treatment, that's a clinical trial and that's separate. But for high-risk prostate cancer, we're not having many insurance issues.
Since you've begun that trial, there have been a lot of innovations in the treatment of high-risk disease. Are you using deciphers, Zytiga, PSA PET scans for it?
Those are all great questions, and those are all great innovations, and we do use them. And so maybe let's talk about what those are, just to explain them in turn. So for Decipher, and I'm sure many of your audience is already familiar with this, but just to catch everyone up to speed, Decipher is basically a genetic test, essentially, of the tumor. So, usually when we think about is the tumor aggressive or not, we talk about the Gleason score, the size of the tumor, even on MRI or on exam, and then the PSA level. That's how we define the risk groups. That's not truly at the level of personalized medicine, right? It doesn't tell you anything very specific or detailed about the tumor itself. Decipher is a test where they look at the gene expression of the cancer, and they give it a score, which is kind of cross-referenced to a group of men that had surgery. Where it was derived was a group of men who had surgery and were followed, and we know how those patients did, essentially. They were treated from 1987 to 2001 at the Mayo Clinic, and so we have outcomes. We know how those patients did, and we know what their genetic profiles are, so it's kind of like a matching. That's a loose way of thinking about it. It's obviously a little bit more complicated than that. But what it can tell us is if someone has a high-risk prostate cancer, that a Gleason 8 in one core, but everything else is favorable, we know cognitively is different than Gleason 9 and 12 cores with a big giant tumor. But this gives us another data point, really. Is this a decipher that's means the genes are more like an intermediate cancer, even though we would call it a high-risk cancer? Or conversely, is it an intermediate risk cancer, but it is maybe a little bit more aggressive? I am using that. It's not covered by many insurances, although now it's actually part of the NCCN guidelines for 2020 for the upcoming year. So it should be much more accessible to patients. Medicare does cover it, and so I try to get it as often as I can. Can we hang our hat on it? No, but I think it adds to the discussion, certainly. So if somebody with high-risk prostate cancer, we get a decipher and it comes back as low, that's very reassuring that potentially we can consider, if the patient isn't tolerating hormone therapy, maybe stopping it early, or it becomes more of a discussion. Whereas if the decipher is very high, we want to really stick the course with the hormone therapy. So that's kind of the way that I'm using it. It's currently most well studied as what's called a prognostic marker. So if you have a high decipher, it tells you the cancer is aggressive. It's not yet validated in the intact prostate setting to be a predictive marker, which means it doesn't necessarily tell you that someone with a high decipher benefits more from adding additional medications. There are trials underway to answer that question. It cognitively makes sense, and so we use it as part of the discussion. There's a long-winded way of saying, yes, I try to get it when I can, and I think it adds a data point to the discussion when talking about hormone therapy, duration of hormone therapy, and our plan of attack.
So if Decipher shows really high risk, do you try and put Zytiga in there with the hormone therapy?
Yes. So I think so. I think you could certainly make a case for that. That's the design of an ongoing randomized trial to be, to try to prove that that's the situation in which you would use added ADT for someone with high-risk prostate cancer if their decipher is greater than 0.85. And I guess that's a nice segue into the next thing. So Zytiga or abiraterone is an advanced ADT drug, and the best data to support using it actually were presented a month ago in Europe from a big trial called Stampede. They found that certain patients with high-risk prostate cancer benefited in terms of survival endpoints from adding Zytiga to standard Lupron, or standard ADT, which was generally Lupron. Who were those patients? They had to have two of the three following criteria. One is Gleason score 8 to 10. Two is PSA greater than or equal to 40. And three would be what we call cancer growing outside the capsule of the prostate or into the seminal vesicles, which would be T3 disease, which they did define based on MRI, which is an important clarification. It's not just physical exam, but even if the MRI shows that. So anyone with two of those features, two of those three things, I am routinely referring them to a medical oncologist to prescribe a medication like abiraterone. Sometimes the patient might not be a good fit for abiraterone because they have some kidney or liver issue, and they may try another medication called apalutamide or Erleada. But in general, I guess the philosophy that I have is if someone is meeting those criteria, they're not just a run-of-the-mill high risk, but they have some specific, more aggressive features, I do recommend they see someone to talk about adding an intensified hormone therapy. And your question about the decipher, yes, if someone has a decipher 0.85, but maybe they don't have those other things, I still might consider referring them off of trial to talk about the benefits and risks of adding this medication.
And I believe the Stampede trial also included positive lymph nodes in their selection criteria.
They did. So that was a set. They were basically, it's a great trial. They included almost 4 different groups of patients. So the first was the group I just talked about, the high risk that have 2 of those 3 criteria. The second was what we call clinical node positive. That means actually not based on PSMA, but based off of a plain old CT scan or MRI. If any lymph node was seen that's more than 1 centimeter, those patients were also included. They also included patients who recurred after primary treatment, but that was a very small number of patients on the trial. And then finally, patients with metastatic prostate cancer. So these advanced drugs really benefit pretty much everybody that was included on that trial.
That's great. And I think we're all waiting for the UK PACE trial to prove that SBRT in a randomized comparison is as good as IMRT.
Yeah, and so as you said, that's one of probably the biggest trials that's looking at that, randomized trials that's looking at that. I think there's also an effort in India as well. But I think that will be the gold standard, of course, if you see that in a randomized trial. But interestingly enough, and I think it is worth pointing this out. So on the US trial for high-risk prostate cancer, the current US randomized trial, which is called Energy G009, that's the one I mentioned where for high decipher, they're adding this advanced ADT. SBRT is considered a standard option for radiation. So in this country, the randomized trial that's being run says that SBRT is not the question. The question is the hormone therapy. The SBRT is a perfectly legitimate option for treating high-risk prostate cancer. So I think the philosophies may differ based on the continent that you're in. What's the standard approach and what's not. Obviously, a randomized trial will be very nice to see, and I'm glad that the UK can do a randomized trial like that. I guess my 2 cents are, why would it be different? Right? If the cancer that we're treating is not different, maybe in some cases the volume is a little bit bigger, but there's been no evidence from any of the other trials looking at what we call moderate hypofractionation, like the 20 treatment regimen. All the assumptions that went behind that panned out for high-risk disease. Why wouldn't it pan out for SBRT? It oncologically should work out, right? So,
and from the patient's point of view, just going in for 5 treatments instead of going in for 20 or 44 treatments is such a big benefit. So I hope it gets wider acceptance throughout the world. And speaking of the world, you changed the way people are looking at international randomized clinical trials with your MARCAP analysis. Perhaps for the patients, it would help if you'd briefly outline what we mean by levels of evidence and why MARCAP is at the top of that.
Sure, and thanks for your kind words. So essentially, when we think about levels of evidence as physicians and as patients as well, what that means is how strong is the science supporting a recommendation of a treatment, and kind of at the bottom would be expert opinion or a case series, and that's kind of it's an anecdotal experience. A randomized trial is very high level evidence. In a randomized trial, I don't get to cherry pick who's getting SBRT, for example. Everyone is eligible for SBRT, and the trial we ran for the MRI device was like that. I'm not cherry picking the best patients for an MRI. Maybe it's equally distributed who's getting an MRI or the other treatment. But individual randomized trials can have some limitations, right? I mean, you could see something as a fluke result. You could potentially, things are related to whatever country that trial was run in. And so at the very highest level of evidence is something called an individual patient meta-analysis, where you have multiple trials and you get all of the patient data from each of those trials, pool them together, and kind of do a bigger, it's all like you're pooling all the patients and then kind of evaluating the randomization. So, if, for example, if you had 3 trials that were looking at radiation versus radiation plus hormone therapy, you get the data for all of the patients on those trials. You pool everyone into a group of no hormone therapy and a group of with hormone therapy, and then you analyze it. So you're kind of building up the level of data that you have to support any claim. So that's the benefit of a meta-analysis. And some things in prostate cancer, as you both very well know, are very controversial. And potentially for good reason. So one of those is the use of hormone therapy, because hormone therapy has so many potential undesirable side effects that there's been a lot of efforts looking into, can we omit hormone therapy? Maybe if we give a high enough dose of radiation, we don't need to give hormone therapy, or maybe in certain groups of patients, we don't need to give hormone therapy. So use of hormone therapy was one of our major things that we looked at in our first analysis from MARCAP. And MARCAP, by the way, is just an acronym for meta-analysis of randomized trials of cancer of the prostate. And it's a global effort where we're getting data from all of these different trial groups from across the world so we can do these types of studies.
How did you do that? How did you get that cooperation from all over the world?
I asked nicely. It's a lost art. No, so people. I think people do like to collaborate, but it can take a little bit of perseverance. So there's channels you can go through. For example, you can approach a trial group in the U.S. that's called the NRG. It used to be called the RTOG. You can submit an application and say, here's what I'm going to do with the data. Can I get some data? Sometimes some money, some financial support is required for that. Then they give you the data and you run your analysis. And so we kind of did that for as many trial groups across the world as we could. And sometimes it did take me being a little bit annoying. I can be persistent. And so ultimately, I think it paid off. And my hope is that, once we have a good result published, and showing, hey, look, this approach works of pooling all this stuff together, more people will be willing to contribute trial data. It would be a shame if they weren't. So.
You are just amazing at putting together groups like that. One of the analyses you've done is for brachytherapy in very high risk prostate cancer, and you've put together a consortium of, what was it, like 20 different hospitals pooling their data. It was an amazing effort. And so how is that different from the kind of randomized trials you've pulled together?
Yeah, it's a great question. Again, thanks for your very kind words. I'm fortunate to be in a position where I can ask people for data. And at this point, people do respond to my emails sometimes. Early on, there were a lot of cold emails, and more persistence was required. So the Gleason 910 or high risk consortium, we had basically data from 16 centers, but the main difference is that wasn't randomized. And so there's something called selection bias. What that means is, if we, an obvious example is if we look at patients getting surgery for prostate cancer and patients getting radiation for prostate cancer, on average, they're 10 years older, the radiation patients. So if we just compared surgery patients versus radiation patients, and even if we went to the best centers in the world for surgery, best centers for radiation, there's a fundamental difference between those groups of patients, right? One patient's much older. A lot of patients in the radiation group are not medically fit for surgery. They have other medical problems, and it's not the same as a patient has an equal chance of getting surgery or radiation. They're equally potential good options for the patient, and a coin is flipped to determine that choice. So because of selection bias, we always have to be careful when we look at what we call retrospective data, which is what that high risk consortium was. Now, I still think those types of work, like retrospective data, are important because they can point out patterns we might not see. Or point out questions that we need to answer in the next randomized trial. You can't run a randomized trial for everything. And certain groups of patients may not be well represented in randomized trials. So there's still a place for doing that type of work, maybe to augment conclusions from randomized trials. But the randomized trial is always going to be the gold standard. That's the proof that you can get in. And the meta-analysis of randomized trials is just one step above that, because a single randomized trial could have some limitations.
And at the bottom of that hierarchy is, I think, database analyses.
Sure.
And what are the problems with that?
Sure. So I think there's a couple of problems with that. I think these big databases, and what you're referring to is, there's something called the National Cancer Database, or NCDB. There's also SEER and those are both U.S. databases. There are other databases outside of the U.S. They're very good for looking at population trends. So if you wanted to ask how many patients in the U.S. are getting prostate SBRT, that's a great resource to look at for that. Or if you wanted to look at disparities in access to care, those types of questions, those are very important things that you can answer. But the problem is those data are even more limited in terms of what type of things they take use of. For example, in SEER, you don't have data on the duration of hormone therapy that's used. You might have a yes or no variable for did the patient get hormone therapy with radiation, but you don't know for how long. And we know from so many randomized trials that the duration of hormone therapy is very important. And in this setting, we don't even have that information, right? So oftentimes we only have one endpoint, which is overall survival. In the NCDB, for example, you only have overall survival. We know that a man's journey with prostate cancer, overall survival is not the be all and end all. There's many earlier stages of disease. It could be cured offhand, or it could come back and be recurrent but managed. Overall survival is a very end of the line endpoint, right? And even in SEER, they have prostate cancer specific mortality. Did you die of the prostate cancer? But they don't have the earlier endpoints, which are far more commonly encountered. So I think you're exactly right. When we look at these types of like big data, at the bottom would be any type of comparative effectiveness research that uses those databases. Then above that might be really well curated institutional databases, which I like to think that our highrisk was like that. At least we had all the data on what the patients received in terms of their treatments, and we had the earlier endpoints, but still limited by selection bias. Then the randomized trial would be above that, and the meta-analysis would be at the top of that.
So on randomized trials and on the multi-institutional retrospective trials you do, you've minimized the number of variables called confounders that could be that are unmeasured often in these large databases. Mm-hmm. What did you learn so far with MARCAP?
Sure. So I think the first questions that we asked with MARCAP, and this is very much an ongoing project where we're trying to build a consortium and ask other questions, but the first ones we wanted to ask were about the use and the duration and in what direction for the hormone therapy. And what I mean by that, again, hormone therapy is just a treatment that's given along with radiation for prostate cancer. A little bit of a misnomer sometimes that we're not giving hormones, we're taking them away. So perhaps a better name is androgen deprivation therapy, or ADT, which your listeners may have heard about it referred to that way. So the question we asked was, what is the benefit? Can we quantify the benefit of adding hormone therapy to radiation by looking at these multiple randomized trials? And are there subgroups of patients who don't benefit? For example, patients getting high dose radiation, patients over the age of 70, or patients, maybe with intermediate risk disease. And what we found was that we couldn't identify a subgroup that didn't benefit. Everyone benefited from adding hormone therapy to radiation if they had intermediate or high risk disease, if they got high dose radiation or low dose radiation, or if they were over 70 or less than 70. And the number needed to treat indicated that we could avoid one distant metastasis at 10 years by treating on the order of 10 to 15 patients. And it depended on the risk group, what exactly that number was, but that's, a pretty big effect, right? So obviously hormone therapy has side effects, right? And it can be unpleasant to undergo hormone therapy, but it's added for a reason. It's not that it's not effective. It is oncologically effective. It's effective and it improves cure rates against the cancer. So that was one of the major conclusions, was really it was a robust benefit to adding hormone therapy regardless of these other variables. The other thing we looked at, it was prolonging hormone therapy. So when we add hormone therapy, sometimes it's 4 to 6 months, sometimes it's longer than that, and that decision is often made based off a patient's risk group. But it can be, prolonged in different ways. So you can prolong the portion of hormone therapy that's before you even get radiation, which is called neoadjuvant, or you can prolong it after you get radiation, which is called adjuvant. There actually are potential scientific benefits for why, scientific explanations for why one might be better than the other. And very, very briefly, I think one easy to understand explanation could be this. When we treat something with radiation, how are we killing it? We're damaging its DNA, and then the cancer can't divide. If it tries to divide, it dies. prostate cancer is smart and it uses hormones, testosterone, to loosely speaking, to repair its DNA. Testosterone pathways are related to DNA repair. That's why depriving testosterone and doing radiation together is very effective. More than that, there's mounting evidence that when you treat with radiation, it is an ongoing process of the cancer dying afterwards. So having a prolonged period of low testosterone afterwards is potentially beneficial in terms of making sure the cancer dies and goes away. And there might be something called feedback, where when you're doing radiation and it's damaging the DNA, the cancer, again, unfortunately, is smart. It might try to upregulate or kind of dial up its ability to respond to hormones. And so having that really depriving the hormones after the radiation, again, might be critical. Whereas before, it makes sense to prolong it before. If you want to shrink the cancer, maybe shrink the prostate down to make it easier to deliver the treatment or something like that. But there aren't as many other scientific explanations for why prolonging it before would be particularly helpful. It would mainly be for logistics or shrinking down the prostate. In any case, there have been trials that have studied these, right? Looking at prolonging it before or prolonging it afterwards. And to be honest, the trials that prolonged it before, they didn't prolong it for as long. They prolonged it for a shorter amount of time. Whereas the trials that prolonged it afterwards, they prolonged it for a long period of time, like 18 to 36 months versus 6 to 9 months before. But what we found was that prolonging hormone therapy before radiation had no benefit at all, not a benefit on any single outcome. But prolonging it afterwards had a huge benefit, very similar to the benefit from adding hormone therapy to begin with. And that benefit was present regardless of the dose of radiation that was given, regardless of the age of the patient, and regardless even of the risk group, which I think is surprising. Because oftentimes with intermediate risk disease patients, we think that it won't benefit as much to do long-term hormone therapy. We're talking about short-term hormone therapy. But in this particular analysis, the benefit existed even in intermediate risk patients. But I do think we need to be careful about what the absolute versus the relative benefit might be, right? So when you say that prolonging hormone therapy in an intermediate risk patient from 4 months to 18 months cuts in half the risk of a distant metastasis, that's an impressive benefit. But you also have to think about what is the risk of distant metastasis. If you're taking it from 4% to 2%, that's a little bit different than in a high-risk patient if you're taking it from 30% to 15%, right? So the bang for your buck might not be the same in intermediate risk versus high risk based on the absolute chance that you might have a metastasis. But the relative benefit is still there. And I think that was one of the major conclusions. And again, it's only there if you're prolonging it afterwards, not if you're prolonging it before.
Are you able to use the database to segregate unfavorable intermediate risk from favorable intermediate risk?
Yeah, so that's unfortunately not possible for the majority of these trials because the era in which they were done was before people collected that information. So that's unfortunately a limitation, right? When we're talking about intermediate risk here, it's regardless of whether it's favorable or unfavorable. But on that note, there was another study that recently was presented, and it was a trial from the US called RTOG 0815. And it was a randomized trial of radiation alone at a high dose versus radiation at a high dose plus a short course of hormone therapy. And that trial did include both unfavorable and favorable intermediate risk patients. It was also recently presented and it showed a benefit in both groups of patients as well. But we need to wait for the publication and maybe get a little bit more into the nitty gritty. As far as MARCAP, we will try to do an analysis when we get more trials in the modern era where we can maybe do that analysis of looking at favorable versus unfavorable. But for now, it's not possible to do that because we don't have the data required.
Another benefit of pre-treatment with hormone therapy is for post-prostatectomy patients who need more time for healing after surgery.
Yeah, and so I think that's a great point you're touching on. So first, our MARCAP consortium analysis so far is purely for the intact prostate, and the relationships in the post-op setting could be very different. So these don't necessarily apply to the post-op setting. But second, I think what you're bringing up is very important. When we say that the neoadjuvant prolongation of hormone therapy, or kind of extending hormone therapy before we begin the radiation, doesn't help, that's all it means. It doesn't help control the cancer more than if you had given a short duration. It doesn't hurt either. So it's not like you're putting yourself at risk by going on hormone therapy for a longer period of time. You know, one example of why you might do that is, as you mentioned, for someone that has surgery and they're undergoing radiation, but they want to recover more continence beforehand. Maybe in the setting of an intact prostate, I think two examples of this would be, first, for logistical reasons. You know, if someone is diagnosed with prostate cancer, they want to do radiation, but they got to arrange some things before they can do it. You can start hormone therapy beforehand. It will put the cancer in hibernation. It will not increase the risk of the cancer progressing just because you're on hormone therapy for a prolonged period of time beforehand. And then second, sometimes patients have a lot of urinary problems, but they still want to do radiation, and we might consider doing a procedure like a TURP or a HOLIP or something to open up the prostate to allow better flow of urine before we do radiation. Those patients, analogously to the surgery patients, we want them to heal up from that procedure before we jump in with the radiation. So that's someone where you would prolong the duration of hormone therapy before. It won't hurt them. So I think it's equally important to say that it won't hurt them as it won't help them, right? It's something that can be done for logistical purposes and is fine, but we shouldn't be doing it to try to improve control rates.
It's just great stuff, and we look forward to the further analyses you do on that. Let's move on to PSMA PET scans, which I know you've been very involved with. We talked to Dr. Calais already about this. Do you think PSMA will replace bone scans and CTs?
Yeah, I mean, I actually think it can. You know, the trial out of Australia, the ProPSMA trial, it was a randomized, so we're talking about levels of evidence. It was a randomized trial where patients either got the standard of care imaging, which would be the bone scan CT, or they just jumped straight to the PSMA, right? And they found that there wasn't too much lost by jumping straight to the PSMA. Now, we're a high volume PSMA center, so on occasion, has there been any instance ever where there might be something that didn't light up on a PSMA, but maybe having the additional information from a bone scan can help? Of course, that can happen, but I think the vast majority of cases, I think it's reasonable to jump straight to PSMA if it's available. And that's what that trial from Australia showed.
Well,
but I guess if I get one quick clarification, the important reason that you might not do that right now is because PSMA is so new that all of these risk distribution and staging systems that we make all our treatment decisions based off of, they're based off the bone scan. What that means is if someone has a metastasis that's only seen on PSMA and not seen on bone scan, they technically wouldn't have ever been on these trials that we talk about for metastatic prostate cancer. They would have been in a high-risk prostate cancer trial, for example. So we need to be careful we're not overstaging patients. And so because the data have not caught up with this imaging test yet, I think for now there's that reason to get these scans, to make sure that we're not jumping ahead of ourselves in treatment recommendations. So for now, I think it's reasonable to get the bone scan just to confirm what the patient would have been staged at, which is separate than saying, do they actually need it to find additional disease? I don't think we need the bone scan to find additional disease, but do we need it to kind of know how to think about and categorize the patient in terms of the evidence that we have? Yes, for that reason, we do need it.
Yeah, the trials on debulking the prostate after metastases have been discovered were all based on bone scans and CTs. And that dividing line at 3 metastases, no more than 3 metastases, was characterized on bone scans. So I don't know how you would use PSMA to make those decisions.
Yeah, and so that's exactly right. So it's because the data that we have not caught up yet with this imaging test that we would need to get a bone scan. So it's not that we would expect, if let's say we find 3 things on a PSMA, it's not like getting the bone scan we expect to find a 4th, right? What we're trying to do with the bone scan is, do those 3 show up on the bone scan or not? If they show up on the bone scan, then we know, okay, you're right at the cusp of whether prostate-directed radiation might help you. And if they don't show up on the bone scan, then we need to think, well, obviously this isn't as advanced as some of those patients, right? That had, clear metastases to bone scans. Maybe we can treat you more like a high-risk prostate cancer patient, but we should take into account there are these things in the bone, so potentially we can, treat those things in the bone or something like that. I guess the major thing we want to be careful about with PSMA, in my opinion, is depriving a patient of a treatment that might help them just because we saw something on a scan. And I think that's what a lot of people are worried about with PSMA. That patient that shows up with a negative bone scan, but a couple of nodes on their PSMA, or maybe 1 node outside the pelvis on their PSMA, do we really want to consign them to having metastatic prostate cancer, not doing local therapy, putting them on lifelong hormone therapy when this is something we just found on an advanced scan? Maybe that patient should be treated more like a high-risk prostate cancer, where we have a finite duration of the hormone therapy, but we take into account what we saw on the PSMA scan. And that's actually, we do have a trial where we're looking at that. It was called the PSMA DRT trial, where we randomized patients to PSMA or no PSMA in the upfront setting. But as you might imagine, that trial is going to be very hard for us to continue now that PSMA is offered and approved by insurance, right? So yeah, that was a trial where patients could get the PSMA for free if they were randomized to that arm, but otherwise they wouldn't get the PSMA at all. But now that it's approved and it's in the guidelines, we can't deprive a patient of PSMA just for that trial. So we'll see what that trial shows. We randomized close to 50 patients, and we had that window of opportunity to do it. But otherwise, I think the PSMA, the cat is out of the bag, right? So we have to think about how we integrate these data as we move forward with practice.
And I don't know if you've had a chance to review it, but recently NIH published that sodium fluoride bone scans are better at detecting bone mets than PSMA scans. So I hope we don't lose sight of that. But you're raising a good question, like, what is the real benefit of finding every single metastasis that's detectable by whatever technology we have? We don't have the randomized clinical trials yet to prove that it's a benefit.
Yeah.
One of the interesting changes, I think, was that energy oncology expanded the lymph node field, the pelvic lymph node field. So what we used to call stage 1 M1A, well, I guess it's still M1A, but it's part of what we're now looking at as a curable prostate cancer, but we don't have the data yet to prove any of that.
Yeah, and you bring up a very good point, with these changes that are being made potentially too soon. I guess the counter to that might be that maybe those never should have been called metastatic, right? As you know, for someone that had surgery and they had positive nodes at the time of surgery, there was an old trial, the Messing trial, that said, those patients should get lifelong ADT. But I think we've come to recognize that, that's maybe not entirely reflective of the natural history for everybody. So I think you bring up a perfect point, but I think the counterpoint that some might say is that, well, clinical node positive prostate cancer, that used to be, we thought that was metastatic, right? Wouldn't offer local therapy. But now we know from Stampede that we should, right? And many of these patients, they can have very durable response rates, potentially even cures with advanced ADT and radiation. So it's just there's just limited data for some of these specific circumstances and forcing us to rethink the staging system for prostate cancer. I might just very quickly add, again, a great point you made that we don't have randomized data to show the benefit of this, except for Axiom in the post-op setting, there was a trial called the Empire trial that looked at, someone that comes with a rising PSA after prostatectomy and they're about to get salvage radiation. Is there a benefit to getting an Axiom scan? And that trial was published in the Lancet last year. It did show an early benefit in a PSA-based endpoint called event-free survival. So there could be a benefit in terms of, in that specific setting. Are we aiming at the right place? Right, which is something to really be of consideration in the post-op setting, right, where we don't know where the cancer is coming from necessarily. If we can find a target on a scan like a PSMA or an Axiom, that probably will be helpful. You're right that the data for the PSMA right now, we don't have randomized data yet. I think UCLA did run that trial for the post-op setting, and so hopefully at some point in the next year or two, we will have the randomized data to support PSMA in the post-op setting.
Well, I don't want to take any more of your time, and I could go on for hours talking to you. It's always fascinating. Daryl, did you have any further questions?
I think this is deeply informative, energetic, fun. Just a quickie, when somebody's concerned about having a full bladder, isn't there a during SBRT, isn't there a medication that could be offered to reduce that urgent feeling?
There could be. I mean, so there are medications that are called like anticholinergic medications that can treat urgency. And so you could use those in theory to reduce the urge to urinate. I try not to use those because they might have some other side effects, potentially dizziness, dry mouth, can cause some confusion depending on who the patient is. So I think it's more that as long as they have a comfortably full bladder, and that was a great point that Allen made, they have to feel comfortable holding it potentially for 30, 45 minutes. But it doesn't have to be bursting at the seams full. That would pose a problem.
Yeah, thank you for that. Yeah, and who knows what comfortable is until you actually go through that.
Right.
So, okay, well, listen, this was great. I think our audience has benefited a great deal, and will probably want to watch this multiple times to sort of harvest all the useful points and opportunities that you outlined, as well as giving optimism for the very useful investigations that you're involved with and your colleagues are, and that we have yet to hear extraordinary outcomes from one or two of the things you mentioned. So looking forward to that. Thank you very much for the care you give to your patients. Thank you for being part of our faculty, and welcome to our conference.
All right, well, you're very kind. And if I might just quickly say, the work that both of you do is incredibly important as well. And as a provider, I can tell, so many patients benefit from having good patient advocates and, intelligent, articulate patient advocates that really have embraced that culture. And it's really important. And I thank you for the work that you both do.
Thank you.
Thank you. Okay. See you soon. Bye.
Bye.